This unit is on vascular pharmacology. Within this lecture, we're going to look at the clotting cascade and some of the blood tests that we can use clinically to assess coagulation. And then we'll go on to talk about different anticoagulants and antiplatelets that we can use clinically and some of the indications and monitoring that we need to do for them. We'll round off the lecture by talking about this general term that's used a few times in vascular surgery of best medical therapy. We're not going to go into a great amount of depth about the coagulation cascade, just to remind you that it is this sequential system of clotting factors and coagulation factors that activate one another in an amplification system that ultimately results in the conversion of prothrombin, or clotting factor 2, into thrombin, clotting factor 2A. The thrombin then goes on to activate fibrinogen into fibrin, and it's this clotting factor 13 that helps to cross-link the fibrin into the ending fibrin clot. Two significant factors that are involved in the clotting cascade are factors 10A and 5A that work together in a complex to activate prothrombin into thrombin. We can split the clotting cascade into an intrinsic and an extrinsic pathway that converge into a common pathway. In reality, the clotting cascade is a bit more dynamic than that, but it's a good way to think about it. And it's essentially when we have the internal and external environment of a vessel interacting with each other, we get the release of tissue factor that comes into contact with different clotting factors that creates the initial activating event for the clotting cascade. Well, don't forget that outside of this, you also have different activities happening with your platelets. You have the von Willebrand factor being exposed on the endothelial surface that interacts with platelets and allows them to aggregate and adhere to each other and create a thrombus as well as a fibrin clot with the clotting cascade. The clotting cascade is a prothrombotic process, but it's something that needs to be regulated within the body. The body has its own antithrombotic mediators that work within the clotting cascade to make sure that this clotting process happens at a more regulated local level. So we have things like TFPI, antithrombin, and then these protein C and protein S that help to inhibit various clotting factors to make sure that this fibrin clot is regulated. Important points to remember about the clotting cascade is that ultimately all of the clotting factors are produced by the liver, including all of the inhibitors, protein C and protein S. Our vitamin K dependent clotting factors are factors 2, 7, 9 and 10, and these are the ones that are going to be inhibited in their production with the use of warfarin, a vitamin K antagonist. There are some non-liver dependent components. There is a portion of clotting factor 8 that's produced by the endothelial cells within the liver as opposed to the liver cells directly, and a von Willebrand factor is not produced by the liver. The tests that we use clinically to monitor clotting are our APTT and our PT, so our activated partial thromboplastin time and our prothrombin time. The APTT is more of a measure of the intrinsic pathway and common pathway, whereas the prothrombin time is a measurement of the extrinsic pathway. Another commonly seen test clinically is the International Normalized Ratio, or INR. This is a standardized clotting measurement derived from prothrombin time that we use to monitor warfarin and also the synthetic function of the liver to assess exactly how anticoagulated someone is. So in the most simple terms, the higher the INR, the thinner the blood is. This is just a little diagram just to demonstrate exactly where the extrinsic and the intrinsic pathways are and which factors the APTT and PT measure and where they overlap in the common pathway. It's outside of the scope of this lecture, but it's also good to be aware of some of the clotting disorders that can happen, whether they're bleeding disorders or thrombotic disorders. And I've just taken the care to highlight some of the ones that you may encounter more commonly through your medical school studies. There is a reference at the end of this lecture to a clotting cascade overview that goes in depth into some of these coagulopathies. Discussing some of the anticoagulants in a bit more depth now, we have a vitamin K antagonist, warfarin. Warfarin is used quite commonly to anticoagulate patients, and there are a wide range of indications for it, ranging from atrial fibrillation, metallic heart valves, all the way through to anticoagulation for pulmonary embolisms and DVTs. Warfarin has quite a long half-life, which means that dosing for it can be a little bit complicated, because you have to think ahead a little bit about the trend of where the INR is going versus the dose that you're giving. Warfarin is a thoroughly tried and tested medication. However, it's a little bit old school and it interacts with quite a lot of different things. One of the common things in your exam scenarios would be to learn some enzyme inhibitors and enzyme inducers that may affect the clearance or retention of warfarin within a patient's system. This can often mean that clinically a patient's INRs become deranged when we start them on certain antibiotics, and we have to think carefully about the dosing or completely anticoagulate them and put them onto something a bit more ideal in the meantime. One thing to be aware of about warfarin: when you first initiate patients on warfarin, as it starts to antagonize the vitamin K pathways, it affects the antithrombotic proteins, protein C and S, before it affects the clotting factors. So initially, when starting somebody on warfarin, you need to cover them with another anticoagulant like low molecular weight heparin until they're fully established and fully anticoagulated. So as we've mentioned previously, we monitor warfarin with INR, and we can adjust the dose based on how high or low the INR is and where the trend is going. Depending on how we need to reverse warfarin, we have a few different options. Obviously, progressing towards surgery, there is a need to reverse all anticoagulants, and we need to consider the risk and benefit of this. Although patients need to be anticoagulated for whatever indication, if we're going to be cutting them open and doing surgery, they need to be coagulated so that there is a reduced risk of uncontrolled bleeding. In the non-acute setting, if we're booking somebody for elective surgery, then we will probably ask them to stop warfarin a few days prior and have the INR tested when they're admitted to hospital. And if need be, we can tweak a reversal agent from there. We can give patients vitamin K orally or IV and recheck their INR in 4 to 6 hours to assess whether there has been adequate reversal of their coagulation. In the acute setting, if somebody is having a major bleed, then we can look to doing something more complicated and giving them human prothrombin complex. Depending on how quickly or how much of this prothrombin complex is given, this can adequately reverse warfarin within 1 hour. So we have a little bit more wiggle room with warfarin in terms of reversing it and fully coagulating patients, whether there is an acute emergency setting or a non-acute setting. We do also have the option in terms of dosing, if patients are a little bit on the higher side but there's no risk of active bleeding, to simply withhold warfarin doses. So we don't have to actively reverse warfarin so much as just withdraw treatment. Aside from warfarin, we also have the advent of these direct oral anticoagulants. They used to be called novel oral anticoagulants, however they're not novel anymore, they're quite well established. And we have a few different options in terms of DOACs. So we have our apixaban and rivaroxaban, which are our factor Xa inhibitors. If you remember back to the clotting cascade, factor Xa dimerizes with factor Va to activate prothrombin into thrombin. And we have dabigatran, which is itself a direct factor II inhibitor. Dabigatran is a unique DOAC because there is a reversal agent on the market for it at the moment. However, it is quite expensive and it's not widely available on the NHS at the moment. With the DOACs, patients are anticoagulated pretty much as soon as they take their first dose. They're medications that work fairly quickly and fairly effectively, and they're quite stable. They don't require any monitoring in the community or any further blood tests to assess the level of anticoagulation. The biggest risk with these DOACs is that, unlike dabigatran, apixaban and rivaroxaban do not have any reversal agents. What this means in the acute setting is that we may need to take drastic actions to replace clotting factors and replace any blood losses. When we think about preparing patients for surgery and asking them to stop their DOACs, we need to consider things like their renal function. Patients that have good renal function would be able to stop their DOACs 48 hours before surgery and be adequately coagulated in time for their operation. However, patients with poor renal function may need to wait 72 hours or longer and have blood testing prior to assess that they're fit for surgery. The indications for DOACs are quite similar to warfarin, so patients with atrial fibrillation or who have pulmonary embolisms or DVTs can all be safely put onto a DOAC. The only indication that's not covered so far by a DOAC is the use of a metallic heart valve. These patients will still need to be anticoagulated with warfarin, generally aiming for a higher target between an INR of 3 and 4, but this will vary depending on the valve being used. And the diagram on the right is just helping to emphasize and show where some of these DOACs act within the clotting cascade in order to reduce the formation of thrombin and thus reduce the formation of fibrin. Heparin and low molecular weight heparin are two options that we have in hospital to anticoagulate patients. Heparin can be either unfractioned or low molecular weight. Unfractioned heparin inhibits factor 10A and factor 2 thrombin, as shown in the diagram on the left. And although this traditionally used to be used in hospital for the treatment of DVTs and PEs, there is a bigger shift towards using low molecular weight heparin now as it's much more stable. So when we start patients on unfractioned heparin, they require constant monitoring with an APTT. Every 4 to 6 hours, patients will need blood taken to monitor the APTT and adjust the rate of infusion of unfractioned heparin to ensure that they're not being overly anticoagulated. Some of the indications for unfractioned heparin today are if someone has an acutely ischemic limb, if they have a particularly large pulmonary embolism such as a saddle embolism, and also unfractioned heparin is used in surgery to maintain patency of arterial grafts. The biggest risk with using unfractioned heparin is that people can undergo heparin-induced thrombocytopenia. So as well as monitoring their APTT to make sure that we're anticoagulating them appropriately, we can also check their platelets to make sure that the heparin isn't interacting with their platelets and causing a large drop. And this is in contrast to low molecular weight heparin. Low molecular weight heparin only inhibits factor 10A in the clotting cascade, and it has a much longer half-life. So what this means is that low molecular weight heparin does not require any monitoring on a regular basis, but we do dose it by patient's weight. And within the scope of low molecular weight heparin, these are things like your Clexanes, your Fondaparinux, things that you'll encounter on the ward, particularly when you're looking at VTE prophylaxis in surgical patients. Low molecular weight heparin is something that we like to use when we're bridging people onto warfarin. Moving on from anticoagulants, we'll talk about antiplatelet medications, another group of medications that are commonly encountered in your medical lives, but also quite important to consider in vascular surgery. So largely antiplatelets are prescribed for secondary prevention of cardiac events and strokes, and in vascular they help to form part of this best medical management for peripheral arterial disease, and also to maintain graft patency and reduce thrombosis in these arterial grafts after surgery. The main two groups that we use are COX enzyme inhibitors such as aspirin, and also these adenosine diphosphate receptor inhibitors or ADP inhibitors, clopidogrel, ticagrelor, and prasugrel. We can either give antiplatelets as monotherapy, so one drug, or we can give them as dual therapy, and this is particularly indicated in ACS management and making sure that patients are on adequate therapy after any ACS event. So aspirin itself is derived from the bark of willow trees, hence the picture on the right-hand side, and this is a COX enzyme inhibitor. It blocks the production of thromboxane A2 in platelets, and what this means is that they're not able to degranulate, meaning they're not able to aggregate, and we don't get any release of local cytokines such as serotonin, creating any localized vasoconstriction. Some of the indications for aspirin, as mentioned previously, cardiac events such as an MI, a TIA or a stroke, peripheral arterial disease, and then maintaining the patency of artificial vascular grafts. Thinking about preparation for surgery, aspirin should ideally be stopped 48 hours before surgery. Depending on the style of operation, it may be that patients are able to continue their aspirin. So if you're operating in an area where you're not hoping to encounter blood vessels, if you were doing, for example, an inguinal hernia repair. However, generally in vascular surgery where your operating site is blood vessels, you'd like to try and minimize the amount of blood loss as much as possible. So ideally 48 hours before an operation is when you would like to stop aspirin. The other major antiplatelet you'll encounter in clinical practice is clopidogrel. So clopidogrel falls into that group of ADP receptors along with prasugrel and ticagrelor, and there's been a lot of evidence at the moment to support the use of clopidogrel over aspirin in managing peripheral arterial disease. There's a lower side effect profile and the outcomes are slightly better in terms of reduced complications. The main mechanism of clopidogrel, by inhibiting and irreversibly binding to these ADP receptors, you prevent platelet aggregation and also fibrin cross-linking. But because we have irreversible binding to these receptors, we find that clopidogrel has a much longer life than aspirin. So when these patients are coming in for elective surgery, we tend to say that they should stop taking their clopidogrel 5 to 7 days prior to surgery. And the last topic that we'll talk about in this lecture is all about best medical management. Along with conservative measurement, pharmacological management of vascular patients falls under this general umbrella term of best medical management. And what this means is that essentially, as part of conservative management and prior to surgical intervention, these patients' multiple comorbidities should be managed radically as much as possible to improve their vascular health, attempt to slow down the progress of any disease, and keep them as stable as possible in the perioperative period. Important medications that form a part of this best medical management are statins, that help to reduce cholesterol within the blood, but also help to stabilize atherosclerotic plaques. An appropriate control of hypertension with any antihypertensive medications, control of any hyperglycemia by controlling any diabetes. So this would be commencing things like metformin, any of the glycosides, or sulfonylureas that might be indicated, and also giving these patients a full cardiac workup to assess for any heart failure, assess for any arrhythmias such as atrial fibrillation, and optimizing their medical management from that point of view. When we talk about managing vascular patients, a good amount of medical knowledge is crucial. And some of the multiple choice questions that we have at the end of this module will look at the management of these various comorbidities. So it would be good to have a look at some of the treatment algorithms for these conditions beforehand. But fundamentally, as a part of this best medical management, one thing that should be encouraged and pushed amongst all patients is encouraging lifestyle changes. So trying to get as much exercise as possible, reducing weight, alcohol intake, and smoking cessation are all crucial parts of improving the quality of somebody's vascular health. So in summary, the clotting process is a dynamic system of thrombotic and antithrombotic processes. Factors 2, 7, 9, and 10 are vitamin K-dependent clotting factors that are affected by warfarin. And warfarin and DOACs act in different ways and must be considered carefully perioperatively. I didn't mention it previously, but one of the main deciding factors between a warfarin and a DOAC are the use of CHA2DS2-VASc and HAS-BLED scores. Due to the difficult irreversibility of DOACs, patients with a high HAS-BLED score may be better established on warfarin as opposed to a DOAC because of the reversibility. However, we do also see that patients that take DOACs have a higher compliance because it's a medication that you take on a regular basis without any need for any monitoring. Moving on with our summary, heparin requires monitoring with APTT. Low molecular weight heparin does not because of its longer half-life. Aspirin and clopidogrel are the most common antiplatelets that we see in clinical practice and both have very different half-lives. Best medical management requires a good pharmacological knowledge of managing cardiovascular morbidities on top of encouraging lifestyle changes. These are some of the references that we use for this lecture. I will highlight again the overview of the coagulation system from the Indian Journal of Anesthesia that goes through some of the coagulopathies in much more detail. There's a good recap of the coagulation system as well.